Where am I starting from? Or are we going to start
We're going to start right from the beginning.
Okay.
And see, now the numbers are going, so we're good. Okay, sorry about that.
That's okay. This is why I don't do video. I only do stills. It's very tricky.
So today is December 3rd, 2015, and we're here with Dr. Robert Goldberg for an interview for the OPA Oral History Project. And we're here with Dick Reinerson and Kathleen Ashton as interviewers. So welcome, Dr. Goldberg.
Thanks.
Dr. Robert Goldberg was born in Brooklyn, New York. He received his bachelor's and master's degrees from Cornell and his doctorate from the University of Michigan. He is board certified in both clinical and forensic psychology by the American Board of Professional Psychology and the American Board of Forensic Psychology. He has advanced training in psychoanalytic therapy and is a fellow of the National Academy of Practice in Psychology and a fellow of APA Division 18. Dr. Goldberg is a recipient of numerous awards and honors, including the Antoinette and Robert Zeiss Award for Outstanding Contributions to VA Psychology Training in 2015, the Distinguished Service Award from the VA Psychology Training Council in 2012, and the Distinguished Contributions to the American Board of Professional Psychology Russell J. Benn Award in 2004. He is an adjunct professor at Case Western Reserve University, Kent State University, and John Carroll University. He is also a clinical professor of psychology with the Case Western Reserve University School of Medicine, Department of Psychiatry. Dr. Goldberg is a member of APA Division 18, Public Service, Division 41, Law, and Division 26, History. He is a member of the Ohio Psychological Association and active in the Public Sector Committee, and is the recipient of the OPA Public Sector Psychologist of the Year Award. He has held numerous leadership positions, including Secretary of the Association of Psychology Postdoctoral and Internship Centers, Secretary and Historian of the American Board of Professional Psychology, Corresponding Secretary of the American Board of Forensic Psychology, and President of APA Division 18, Psychologist in Public Service. Dr. Goldberg has published numerous papers and chapters and presented nationally on topics such as training and clinical competence, history of psychology, and psychodynamic therapy. Dr. Goldberg has been a psychologist at the Lewis Stokes Cleveland Department of Veteran Affairs Medical Center since 1975, where he has held numerous roles, including as staff psychologist in the Mental Health and Inpatient Psychiatry Unit and Associate Chief of Psychology Service. He is currently the Section Chief for Academics, Education, and Training, and has been the Training Director since 1982. Dr. Goldberg has served as Training Director to over 350 trainees, including myself, and thus had a tremendous impact on psychology in Ohio. Additionally, Dr. Goldberg has shown a strong belief in community service in the public sector, including his active service with the Geauga County, Ohio Board of Mental Health and Recovery Services. So welcome, Dr. Goldberg.
Thanks very much for the opportunity.
Oh, Bob, I've known you for a number of years, and I know a good deal about you as a psychologist, but could you say something about why you chose psychology, how you got involved?
Yeah, sure. I was one of a group of about 12 male nerds in high school who were totally inept socially, terrified of girls and women, and liked to talk about it. In fact, we used to be able to assemble 12 of these guys, with all those sluices going through their body for duplicate bridge on a Saturday night. If anybody can conceive of this. Anyway, so in discussing these real and imagined difficulties we were having with these women, I noticed I was getting a perverse pleasure out of listening to this stuff. And I had awareness that there was a profession called psychiatry, which was mostly doing talking at the time, there being very few medications, and that you could get paid for this. Okay? So I went to the public library, and I blundered into a book called Clinical and Counseling Psychology by John M. Hadley, and he described all the professions. This is like a first-year professional issues book for grad students, and he described all the professions first that did psychotherapy, and I discovered that a psychologist at the time made $5 less for an hour of private practice than a psychiatrist, and a social worker made $5 less than a psychologist, and a psychologist was called doctor. And I had this theory that was afraid of the sight of blood. Now that turned out to be wrong. That's why I'm a psychologist, or I would have been if I hadn't thought that, I would have been a psychiatrist probably. So I went into psychology, and actually, ironically enough, I got into Purdue grad school years later, and they assigned me, without any knowing it, they assigned me this guy Hadley as an advisor. So it's kind of a nice little touch there, and in declining that particular offer, I kind of paid my respects to him, but he got me in the field and stuff like that. So that's how I got into psychology.
And it's also of interest to people, I think, how you developed your theoretical approach.
Well, it was based on an epiphany I had on the New York City subway one time, going to a summer job. I was reading Freud, okay? And he put forth the idea that little boys, in order to deny their castration anxiety, believed that little girls didn't have vaginas, but they had small penises, okay? And I said, how did he know that that was my theory when I was 6 or 7 years old? I said, that's it. I said, this guy is dead. I mean, he was dead 3 years before I was born. He never met me. How did he know? So that completely convinced me. That was it. That is true. That was it. And after that, that was it. And I started really like creating my undergraduate program and trying to get into graduate schools that had a heavy psychoanalytic theoretical orientation at the time, of which there were many at the time, which was 1964, 65. I mean, the grad school time. So that's half a century ago. So that's how I got it. That's how I got into that theory.
Mm-hmm. Who were some of the influential psychologists from your training?
I would say, well, of course, it's Freud. Okay. Also, the writings by an analyst, W.R.D. Fairbairn, Fairbarn, who was kind of an object. Now you call him an object relations person, but he was actually very consistent with cognitive theories of Piaget that I was very interested in and had written a little bit about, written some papers for grad school about and published one. And so that was very influential. But Ed Borden, who was a counseling diplomate, one of the top counseling psychologists in the nation at the time, and he's ABEP and was on the board. And Borden was faculty member and supervised me as well. So in terms of like the grad, at that point, those were the biggest influences on me. Those one live, one remote, and one dead.
So I'm interested in your journey to Ohio. So you started out in Brooklyn, New York.
Right.
So how do you go from Brooklyn, New York to Ohio?
Well, how did I go to Brooklyn, New York? Well, first is ruling out Brooklyn, New York. So when I was looking for jobs, things had gotten so bad in New York City that instead the parents on both sides of my wife and I, both from New York, they both said, instead of saying, gee, we want you back, and when are you going to get a job in New York? They said, stay away, you're out of here, don't come back. So I said, so let's try to stay away. Anyway, so actually, I tried to get a job at UC Berkeley, which I did not get, and that's how I wound up in Cleveland, actually. But I really liked it here. Number one, it's the same ethnic mix as New York City. Second, I just thought the eastern suburbs were beautiful. We wound up living in Geauga County for many years, but still love the eastern suburbs. And it was a city, and I like cities. I don't let the reputation of cities, Detroit's bad and this one's bad. I really like cities, and they always have a lot to offer no matter what their rep. So I wasn't deterred by Cleveland's supposedly bad reputation. Cheap cost of living. A lot of traditional and psychoanalytically oriented people in the department, Case Western Reserve Department of Psychology, and they permitted me to teach what I wanted to teach. And so I got a lot of freedom. I actually turned down a job at Carnegie Mellon, which was 50% more money, because I liked the whole gig. And as Imus, people know Imus in the Morning, disc jockey. I mean, I think he's on satellite now, but he was here for a couple of years. He was here for a couple of years, and when he went to New York, they asked him, "What's New York life?" And he said 12 Clevelands. So this is like 1/12 New York, I would say. I never had any interest in moving. I mean, I really like the whole scene here. So professionally, personally, the whole thing. So I never was eager to get back to try to go to California or anything.
And so you arrived at Case Western Reserve after I graduated.
Considerably after you graduated, that's right.
Well, I'm your elder, so.
I'll concede that.
But how did you get from the university to the hospital to the VA?
Well, I flunked academics. I perished rather than published. I permitted myself to, well, I did. I mean, I had mixed feelings about publishing. I was too concerned about narcissistic injury and criticism. And I really talked myself out of there. To be really honest about it, I mean, I talked myself out of there. And clinical is more my strength than research anyway. I mean, I'm not curious enough. Probably some inhibition of edible curiosity there, but I'm not driven enough in terms of curiosity to really search things out. I discovered it myself. Anyway, but I was treated very nicely. I'm still adjunct there. I'm teaching MMPI again. Did it last year. I'm teaching a module the upcoming semester, another few weeks. And Irv Weiner was, in terms of influential people, Jane Kessler, of course, and I think she's a tremendous psychologist, and I had some postdoctoral supervision from her that wasn't required, by the state and licensing laws, but I really value that. But in terms of like career direction, Irv Weiner, and as he was informing me that I wasn't going to be renewed, which he did in a very diplomatic fashion, he said, I envision you as a training director. And some went off in my head, because I had done a lot of supervision in grad school of postmasters educational specialist and doing child assessment. I'd been hired to do that by one of my professors. And I found I liked doing it a lot. And I'd set that up in reserve quite a bit, which people may not remember, but I was doing assessment courses and practica in both child and adult assessment. And I was also doing a psychodynamic practicum, and of course this precluded, and it was an avoidant mechanism from doing research, but that's it. So I will say that the VA did rescue me from penury. My salary went up nearly 60%, my gross salary. And the VA was only about average to maybe a little below in those days, which was 40 years ago, 1975. But I was grateful, for the academic experience. I think it's always helped me in terms of having it on my resume. And I've always enjoyed good relationships there because I understood the part that I played in my own, not succeeding in that realm, in the usual promotion tenure way.
And it was an era when there were some interesting characters there.
At Reserve?
Yes.
Yes, there was Dr. Hertzberg.
Yeah.
Dr. Fred Hertzberg, a motivation hygiene theorist. You know about that? Well, it's a simple industrial theory, but it turned out to be very useful and heuristic. There's a lot of research on it, and he handed out chairs. It's like, there's two things that you might like about a job. The pay, or the concrete reinforcements, like the pay and nice office, or the inherent value of the work. So hygiene factors were things like how much money you got, how many windows in your office, and the motivational factors was your intrinsic enthusiasm and involvement in the work. So he had this theory, but he was, he would be concerned about some of us being involved in, I think the quote was, departmental intrigue. So what could I say about that? So it was difficult to relate to him in a responsible fashion on my part, let me say that. So I didn't help my own cause there in retaining my position. Mm-hmm. And who else was there? There was, of course, there's Kessler. And I gotta say that Hertzberg does stand out in my mind.
Was Marguerite Hertz?
Oh, well, Marguerite Hertz. Marguerite Hertz, I would run into her every so often, the Rorschacher, okay? And I was teaching Rorschach. And she would say, stick to your guns, young man. She would say like that, and then when she was named the Great Man. She got the Great Man Award because that's what it was called, the Rorschach Society, the Society for Personality Assessment. They call it the Great Man Award, okay? And she would, and she got the Great Man Award in one of those times in the early '70s. Yeah, in the early '70s, and she also repeated. She repeated her speech or her acceptance speech for OPA, or for, I must have been CPA or OPA, I don't know. She did it more than one place. And she said, and she would give the history of the Rorschach. And then she said, and then we come to the 60s, she says, psychodynamics banned, the Rorschach excommunicated. So she was pretty with it, And she was, had a lot of energy, and I know into her old age, Dr. Kessler kind of made sure that she had a comfortable and productive old age.
And Bob, did she ever learn your name or remember it?
Well, no. But she recognized me. There was a visual sighting, No, I don't think so, but I understood there was a generation of students that was fearful of her rather direct feedback on Rorschach interpretation, but I never experienced that.
I did.
Oh, did you?
So cases lost was really the VA's gain.
I like to think that. That sounds good. I'm going to have to remind the VA that when the bonuses come around next time.
That's right. So, really this legacy that you've had with training is tremendous. It's how many classes of interns and
35.
35 classes of
Yeah,
interns.
well, it's 33 and 2 halves.
And how many interns do you have in a class now?
This year it's 11. We've run between 7 and 12 over the years, depending on the funding or whether we're taking people without compensation, or what APA thought about it.
And then you were instrumental in developing a fellowship program.
Yes. I would say that my long-term goal there, and I was very patient. It took 30 years. I was very patient with this, was doing postdoctoral residencies, because I became convinced, really, with my involvement with APEP, I became convinced that was going to be the future of psychology. Plus, I've applied for have privileges in many of the hospitals in town, and it's difficult when you don't have a board certification to answer these questions. There are all these different subroutines that you have to comply with, and frankly, I think I considered Psychoanalytic Institute when I was getting out of school, which I rejected, but I didn't really think of the inconvenience later in terms of credentialing and privileging, and in hospitals, and in terms of credibility, and so I really thought that this is a great area to develop. And I actually, in '85, I actually got NIMH money in. I got some NIH money in for a geriatric mental health fellowship. And then that funding expired. And then the VA started offering geropsychology postdocs. And we got one fellow, 93 through 2000. They abolished those, and then competitively, we wound up from 2004 until now with an expanding program. We started with clinical psychology, had 2 fellows, and then we have another fellow in neuropsychology, a separate program, and then we expanded the clinical program considerably. And then in 2013, we split clinical into clinical health, and rehabilitation. So we have 4 separately APA accredited programs now, those 3 and neuropsych, and we also have the internship. So that's the most accredited postdoctoral programs and most total programs accredited for any institution in the United States.
Yeah,
So,
it's quite an accomplishment.
well, yes, I'll say so. I've decided no longer to be falsely modest. Well, you have to see that this is going to be important. You have to sell your bosses. You have to keep your eyes open. And I'll give you an example of that. They were going to. We had 2 fellows, and they were going to have an expansion in 2005. And all the training directors are buzzing on the email. Well, how many of these should we ask for? Well, we're only going to ask for 2. They won't give us more than 2. So around APA, there were a couple APA meetings, VA meetings at APA, and another separate VA conference. And the man who controls this money in central office, people were asking him, how many slots did you have? Well, he said he gave 3 estimates. He gave, I think, 80, 120, and 30. So people were saying, gee, which 2 am I going to ask for? And I said, well, it's obvious to me. This man who's Bob Zeiss, he hasn't the foggiest idea how much money he's going to have. He doesn't know. So why would we be worried about what we're asking for? So I just convinced Dr. Padin, my chief. I said, we're going to put in for 5. And he said, what do you mean we're going to put in for 5? We can justify it. We've got PTSD here, we've got substance abuse, we've got all this, we've got health. So we've got all this stuff. We can completely justify it. None of these is a stretch. Okay? And we're gonna get separate neuro too, and we're gonna ask for another intern too. Why is that? Well, we're gonna intern in primary care. Then we'll have intern, resident, staff member, vertical supervision. There's a concept there. It's not just we want more interns. Somebody is going to read this. And besides which, if they only give 2 to each place, which had always been the custom, if they only give 2 and say they get more money later, our proposal is lying there and they've got nothing else. They give us everything. So they wound up giving us 5 slots. And from there, the money got much more generous. That was the first iteration. They've had 3 more since. And the third one, we had like so many people we can't accommodate them, so we didn't even put in for the 4th iteration because we've got 16 fellows already, 16 full-time postdoc slots, as well as the 11 interns. You know, so there's no more you can do without the. Well, there's no more you can do in terms of numbers, but we never did get geropsychology accredited. The emphasis we have in geropsychology, because it wasn't created as a category in time for us to do this proposal. The last one we did in 2013, so that's left over for my successor to do if he or she wants to pursue that. Because that was the original idea, was geriatric back 30 years ago.
I think you left them with a pretty good foundation.
Thank you very much. But you know, they know what I want to do. The other thing is, how can I say this about foundations? I don't have any fantasies about legacies, okay? Because I have seen in my career, once you retire, which I'm anticipating doing in the spring, after 42 years of government service and 40 with this VA, that the waters close over you pretty quickly once you leave. So I don't need people to preserve heritages, and frankly, if my successor blows up the whole structure the Monday after I'm gone, that's okay with me, because you have to do it's your job. You have to do it. And places I've seen that give too much, in a way, respect, or take into consideration what's gone on in the past too much. Because I've gone on site visits where this is happening. You know, they bring in the old training director with his cane, and they say, "Well, here's the guy. He'll answer a few questions if he can remember, you know, what he did." You know, it makes a bad impression, even if you have a great program. So, you know, as far as I'm concerned, Monday morning after I'm out, I'm sleeping in.
I think around the state, your training program has certainly been acknowledged, in part because you've got people all over the place from it. Beyond the training, what else have you been most pleased about in your career?
Within the state, or anywhere?
Within the state or nationally, what?
Well, within the state, I'm glad that I got involved with the public sector committee. Public sector committee. I actually got into that by accident, which you may or may not know. Dave Aronson had been. I think Cynthia White. Yeah, Dave had lost to Cynthia White. I think 1989 or 90, president of OPA, but it was a close election, and Cynthia wanted him to, or asked him to organize like the public sector psychology into an ad hoc committee, and so David was calling around for people. He was looking for John Lowenfeld, and I picked up the phone, and John Lowenfeld had left the VA. Dave, you know, John's not with us anymore, and so like, what's up? So he had to offer it to me because I was on there. So he offered it to me, so I wound up on the committee. You know, and I think one of the things that, well, first that I got to appreciate Fred Fries so much from interacting with him so much, and like how courageous he's been and how much he's done for Ohio psychology. One of the first things we did early, and I think Cindy Orlasky was the president of the thing at this time, is, as I recall it, and you would know this too, Dick, NAMI was very upset with psychologists because, like we were saying, that the bad mothering, or their idea was that psychologists still generally believe that a bad mother created schizophrenia, whereas they were very happy with a biological explanation that could be fixed with a pill. And I'd say a lot of Ohio psychologists, including OPA people, that were very angry with these NAMI people and really had no appreciation of where they were coming from. And Cindy, as well as Dave, set up a meeting, and it was a rainy Saturday in Columbus. I know we went down there. I haven't checked to see. I know I was there. Cindy was there. Someone from OPA and someone from NAMI was there, and just tried to talk about what the organizations believed and what they were trying to do. And Dave Aronson may have been there too. But I can't, we don't recall, and I can't find it in the records. I mean, I have got about, in the other room, I've got 8 inches of minutes going back to October 1990, but I couldn't find a reference to who was at that meeting. But anyway, so I think things got a lot better after that, and I think OPA is very supportive of me now, and I think that rancor disappeared, and I don't think too many people remember that. Okay, and then I think it may have been Stephanie Zimmerman. Then we got constituted as an ad hoc committee, right? And then we got. I'm trying to get this straight. I think we got designated a SIG, a special interest group under one structure, and at one point, but then we had a vote on the board. At one point, you were I think on the board.
I was at that
in
point.
one or another category. I'm trying to remember this, but I do know that at one point, at another point, like we lost the vote. We lost the vote in a reorganization, and I know we were very upset. And David Hayes came to pat our heads and stuff, and reassure us that we were still loved. But we were not entirely happy about that. And Kathy McDaniels Wilson, I think, she was, I think she did the most for us from OPA at that time, which would have been about 04, because I was coming out of some class I was given at Kent State, and I got paged, and it says it's like Kathy McDaniels Wilson. I said, what? I said, she's calling me? I said, what's that about? What would they have to do with me? I'm very deep on this committee, anyway, so it turned out she wanted to meet with us, and anyway, we wound up with, as she did, right, she rightly noticed that we had kind of become an in-group. There were 7 of us, Cindy Orlasky, Lonnie Everline, Harvey Kane, me, Dave Aronson, Orlasky, and John Thomas. Okay. And there were a couple other folks. I think Barlow was on there originally, and Bayer. Anyway, there's 2 other people, but the 7 of us, the first 7 I mentioned, we pretty much stuck with it, and I think there was a perception, probably accurate, there was too much of an in-group, and that we were getting this victim stance, circle the wagons mentality, okay, and so Kathy appointed Briggs. I think Sylvester. Dr. Briggs as, which is her right. She appoints committee chairs, and frankly, appointing someone from outside was probably a smart move in terms of structure, and we could grumble a little, but we realized it was a smart move, and we didn't have too much problem with that. But the interaction pattern, it didn't work out very well, and I don't know whether Briggs quit or resigned or Kathy said thank you very much or whatever it was, but we did wind up with the board vote, and I guess. Some of my pals are a little concerned that we might not have one anymore, and go back to, how can I say it, to not having a vote. But so that would be the status of the feelings of the.
Yeah.
Right. Well, I'm just saying, that's the history.
Yeah.
That's history. But you also have to realize that, public sector folks, we have this is entirely my theory, does not represent the committee, does not represent, there's always in the public sector, there's always a little bit of a self-esteem issue. Okay? Our tuna sandwiches aren't as good as au bon pain or whatever, or something like that, always a little bit downtrodden. And I actually, one of the papers that I wrote, Psychological Services 2007, the Psychodynamic Organizational Perspective on Division 18, uses this theme of there being a narcissistic insufficiency in public sector psychologists that requires some kind of infusion of a sense of importance from outside so that it'll propel us forward and motivate our functioning. And something like getting a vote would do that. Something like losing a vote would perhaps be even unrealistically damage to a group's self-esteem. Anyway, so that's my dynamics of this thing. And I understand when my paper was delivered as a talk, it was hard to hear it because so many people were laughing. But I do consider it a serious hypothesis anyway, and informed by Kohut and some of the narcissistic theorists. But OPA, what OPA has done a lot for us is first it gave us a vote. I mean, we had a vote, and I think been increasingly responsive over the years to what we have to say. And I think there's a lot more awareness on the part of the members of OPA that there's public sector clientele out there You know, and I remember when I had like 2 minutes to give a lunch speech in 1998, when I got this Public Sector Psychologist of the Year award. I said my only idea was to get up there and say, every time, you guys are in private practice basically, but every time you guys have a Medicare patient, a Medicaid patient, and get any kind of, Champus money, you're a public sector psychologist for that episode of it. And that was the only thing I wanted, except for thanking people, because I thought that was the most important thing to say. And then OPA is perceived, and I don't really know what the numbers are anymore, but as a private practice organization, and to the extent to which OPA can become identified with doing things for the populace and not just as a guild, I think that helps, and I think the Public Sector Committee can contribute. That has contributed, can contribute to it, vote or not.
Yeah. I think the voice of the public sector psychologist is really important, and I think it would be interesting to get your take on what the public sector psychologists, what they give to OPA. What kind of voice do they bring?
Well, we've done educational programs. I'm still trying to catch up on this Amish mental health webinar. I think Van Kuren, I don't know under whose auspices, but Cindy Van Kuren did a telehealth, continuing education. I know we did a symposium on SMI, June 2013. So we've done a lot of continuing education. I think it's the thing we've done most, is also trying to remind people, hey, there's these schizophrenics running around, these kids are not getting any services and whatever. The other thing we've done, like one of the things we did on this committee was, one of the state agencies was trying to, had an outcome measure that was not very good. So I don't know whether we did it through OPA or independently, we recommended that the state use this other outcome measure, which was no more expensive but had a lot more validity, and no more burdensome in terms of length or anything, because that had some validity for seeing outcomes with these kids, as opposed to this other thing they were doing, which was just nonsense. So it's that type of thing.
Yeah.
That type of thing we've tried to do.
Yeah, I think really being the voice of severe mental illness and the voice of the patient population more than
right.
As opposed to, sometimes in private practice the focus is more on the psychologist and what the psychologist's needs are.
We agree. Or I agree.
Yeah.
Thank you.
Yeah. Interestingly, the current president is a public sector psychologist, as well as the finance officer, and I think almost 25% of the board right now are public sector people, so maybe there is a shift.
Well, of course, we've also got more people coming into the public sector, coming in from the cold, actually. I mean, I personally believe that the days of solo practice are over, unless you've got a gimmick being neuropsychology or forensic, And I'm on one of the forensic listservs, and there's just a heck of a lot of people on there. And I said, where do these guys get the time to put answer? Because they're billing X $100 an hour, and they're not billing 8 hours a day, so they've got plenty of time to fool around, and debate and this kind of thing. So I think if you've got a real specialty like that, and especially if you can identify with some kind of diploma certification, it's a boutique operation, and you can probably do okay. As a GP, I don't know if you can practice alone. I mean, I think you're going to have to practice in the groups, whether it's like you've had for so many years, or primary care clinics, integrated care and primary care clinics. And we've been doing that at the VA for a long time, although there wasn't a name for it. The psychologists used to live in wherever it was, cardiology or renal, and they saw the physicians every day. And the psychology chief never saw these people, but they seem to do some work. Now, since you got me started on integrated care, okay, and actually Orlasky, Cindy Orlasky was in on this too. We were sitting 2 years ago. Case Westminster puts on a big biennial psychiatry thing, and it's very good. It has community members, consumers, academic. It's just a great conference. It's a day and a half, and it's in Beechwood all the time. And they were talking about integrated care in one of these rural counties, and it hit me and Orlasky that if integrated care, does that mean one budget line? And if mental health is not split out as a budget line somewhere, medical care is going to wind up taking it all. And there's a structural danger there in terms of, I think, and I'm not a businessman or a hospital administrator, but I think there's a real danger there when they start lumping these monies together, if they ever do, of really losing funding for mentally ill individuals. And that's I don't know, but it's a danger.
Yeah.
But
Yeah.
it's
We're
a
going
point.
with the lowest possible paid mental health provider.
Well, that's bad.
I think there's a lot of that going, a lot of coaching going on.
Yeah.
That,
Yeah.
you know, which is, I think, kind of leads naturally to your interest in board certification and why you think that's important. You've been, very influential in that area as well.
Well, I think it's important as a recognition of expertise, and it's automatic. And what I found is people assume you know what you're doing, rather than you're having to prove that you know what you're doing, even though you might be the same person. It's just easier. It's certainly easier to get privileges. But what it also does, in my opinion, is it's transformative in terms of how you view yourself as a professional. Because, and I've done editorials for the AP newsletter on this, I don't believe that internship, practicum, internship, postdoc, board certification, that's other stuff. Actually, there's going to be subspecialties developed too. But I don't believe that is cumulative. I believe that it's transformative. That not only do you learn more, but your whole body of knowledge and expertise is organized differently. Some skills get sharper, some skills wane. They gain in importance. They become more a part of you, or not, or like child assessment. That has withered in me. Whereas I used to teach child assessment. I taught child psychology. I used to teach child assessment. Quite frankly, I wouldn't test a child now. So, but your identity changes too. And it's not just your skill set. It's, what you do, what you're interested in, who you want to work with, types of problems, intellectual interests. And I always trace my intellectual interests by the divisions that I join and drop in APA. And I think, looking at that, I learned a lot about myself. But so I'm saying, so the certification piece, in addition to convenience and stuff, and in the VA you get money, everyone. To me, it's also an identity thing. And I've seen it, some of my very senior colleagues really change the way they approach the field, or they get more involved in professional organizations. And plus keeps the cobwebs out.
And I wonder if it doesn't certainly modify the way you tend to conceptualize what you're dealing with.
Well, yes, thank you.
When I would come to the VA and we'd review the student presentations, I think that's where it was most interesting to see the different ways people were conceptualizing, and the students' conceptual framework was pretty narrow. And some staffs would be a little bit wider, and then you and others, the old-timers, much broader and much deeper as a result of all of the experience and the certifications.
So I became hooked on it.
Mm-hmm.
But we also the other thing that I try to sell, I guess that's a bad word, but I'll use it. It came out of me, so I'll acknowledge it. The trainees on is, you are going to be taking exams for your entire career. This concept that first you got to get through your doctoral oral, and then you got to get through licensure, then you're like home free. Well, I keep telling these folks they're going to get relicensed. ASPPB has got a task force on relicensure, and for years I went to these meetings like Board BEA or something like that, and Dr. Demers, Steve Demers, executive officer, stand up there and say, well, you have all these ideas, but the states have to agree. And then about 3 years ago, he changed his tune. And he said, well, yeah, about uniform licensure and stuff, yes. And, that you have to be accredited to get a license. You have to go from an accredited graduate program. So you're going to have to be licensed. And so he began to think that's going to happen. And then there's going to be relicensure. I mean, my primary care guy does. I go see him What's that book? Well, I got to get relicensed as an internal medicine every 8 years. I got to get recertified.
Right.
So this is going to happen. ABEP is working on it. They've got a recertification thing.
Yeah.
Yeah, they're starting to do recertification. So this is happening, and and you've got to tell the trainees, this is it. You're not when you duck out of here. That's not it. And so the other thing is when that we did, and this is amazing to me. There is no requirement in any graduate program that you examine somebody on clinical stuff. There's dissertations. There's, but there's no exam. There's no exam. So when Ohio went to, you can get licensed without any postdoctoral experience. I said, that's it. We can't let these folks out of here. We're going to give them an exam. So it's not strictly, it's an exam from California School of Professional Psychology. We tried 4 different models. We liked that the best because it gave a spread of scores. It was the most useful for feedback. But it was an exam experience. So we do an oral exam. And there's a spread of scores. And, so the students are desensitized to it. Or they find out what it's like, and so they're going to get used to it. So it's not going to be entirely unfamiliar to them when they run into it. Or they'll consider it. We had 5 people pass ABEP exams in the last 6 or 7 months with us. I mean, and it's generally the less senior staff.
Yeah.
Because I think the more junior staff has figured it out that they're going to need it, at least in a hospital, that they're going to need it. And they're not all health psychology, but the majority are health neuro.
Those are tough ones to get.
Yeah. Yeah. So, what was the question?
Well, I'd like to hear a little bit about some of your trainees. So, out of these 350 trainees, tell us some of the people you've worked with, or some of the stories you've seen.
I'll do a few vignettes. Dr. Ashton, yourself, you're one of my positive memories. When Dr. Ashton was here was an intern for less than a month, about a month. I was down in the mental health clinic where I ply my trade, and she came down. This was on 9/11. This was on 9/11 too. She reminded me today. So she had the suicidal patient, and I thought I'd hang around just in case she needed a staff member, because she was sent there like without any staff member, without any guidance, just take this guy and get him admitted. And I was really impressed. This was really true. I mean, I don't know if you noticed, I hung around to make sure that even past 4:30, that this patient was going to get in, and But she did it all herself, and I was very impressed. Oh, we're not going to have to worry about this intern, and obviously that was correct. So, and then we had, so that's one positive thing. Well, actually, I don't have too many negatives about the interns, I would say, but then I had one intern who he would always do the white coat thing. He was a neuro intern. He was identified with Dr. Nancy Adams, who was formerly staffed with us, because she always wore this white coat around. So he came around, and he passes my office, and I say to him, I'll have the kidneys flambe. And he cracked up. And I tell you, we're colleagues to this day. That was 18, 20 years ago. He lives in San Francisco. I haven't been out there since he moved there. He says, we'll go out to dinner. He's really quite a character. So, and most of the interns we had have been. Oh yeah, and then we had this was an intern from California. Okay, but I won't give the name because it's one of these unique California first names. Okay, and this woman was totally California. So I got the interns in a group one day, and I guess I scheduled a noon meeting. Okay. And she said, and she raised her hand. She says, "Well, I don't think we should meet at noon." So why is that? She says, we need like self-care and time to think, And I really got irritated. And I said, all you guys are eating lunches here that look like cat litter. I said, these nuts and berries and twigs and stuff. And I said, can't you? I realized this just came out of me. And I said, can't you eat and think at the same time? I said, we're going to have noon meetings. Get real, But this woman was so remarkable. She was just a remarkable person. And she got pregnant at the time. Her husband was in California and stuff. So the intern group adopted her. This was really sweet, okay? They adopted her. And like when she was, close to her time, they had shifts. They were doing shifts, like 12-hour shifts to take her to the hospital if she had to be taken to the hospital. So that was just lovely. And then she had the baby, and then she did a couple X amount of weeks off, and she finished the internship. But the other thing is the interns. This is Freudian, okay? The interns put together a cookbook emphasizing bakery and roasts. And of course, a roast or a cake in the oven is a Freudian symbol for having a baby. But this group that didn't even know this made this cookbook for them. And it was the only time we ever got a group cookbook out of these guys. It was just really delightful. And then the second baby she had, I got on the phone with her about something. She called me up from California. And it turns out she had passed the licensing exam on Thursday. She's calling me on Friday, and she's going to the hospital the Saturday for a baby. So she beat the licensure in there. She beat the second kid by 48 hours maybe. So that's a woman to admire. So I'd say, but most of my, it's not all beer and Skittles. You have issues. You're not everybody's friend. And what I tell the interns at the beginning of the year was, I'm human. I have favorites, but I don't play favorites, and that seems to satisfy them. Because you'll just like some people more than others. There's no way around it, But that's what I've been telling them for years, and that's worked pretty well. Yeah. The other thing is, I assume, until proven otherwise, that one of my interns or postdocs is as good as anybody else. And I find that many of my supervisors, let me say that the biggest factor in supervisors downgrading or underrating a trainee is they don't get their notes done on time. It does not have anything to do with their clinical competence. If their note's not done on time, suddenly there's a halo effect on all the ratings. And so trainees out there, students, get those notes done.
I echo that.
But I consider recommendations advocacy documents. And if people want an evaluation, ask for an evaluation. If you want a recommendation, you're going to get a recommendation. You're going to get an advocacy document. But us training directors complain about, all these are they're all the top 5%. Well, if you don't want that, ask for an evaluation. Don't require a recommendation, or require both. You want to see ratings, you want to see the last clinical placement they had. But don't get mad, when you're not asking for what you want, when you're being polite. But again, that doesn't make me popular with all the training directors too. Because, APA is moving to, APIC now, but it's really, APA too is moving toward what Canada does, which is Canada has, because Canada only has a limited number, a much smaller number of graduate programs and training places. So they are very collegial. It's like a small town up there, and they want to get the best matches and fit. So it's a collaborative effort. Whereas in the United States, this is developed into an adversary process, where the university training director is desperate to get people in, and us internship directors are in the Dick Tracy mode, trying to detect an incompetent intern, read between the lines, etc., etc. And that's not the way it's supposed to be, in my opinion. And finally, APIC went with like a uniform recommendation form that's somewhat similar, although not, in my opinion, as useful as the Canada thing. But I think that'll start to help. That'll start to help things. I think it's been more collaboration because of the gap between the number of slots and the number of applicants.
So do you have any thoughts on a solution to that?
Yeah. Well, I consider it a chronic illness. Okay. See, it's being treated like a crisis. Okay, or like an acute illness. Okay. This has been going on since 1998. So it is a chronic illness. So you have primary, secondary, and tertiary prevention. Primary prevention: stop selling psychology to every undergrad. Okay. Secondary prevention: stop taking so many graduate students. Tertiary prevention: get more slots. Create more slots. And unless all three of those things are done, they're going to limp along like this forever until some of the PsyD programs become insolvent, just for whatever reason. Now we have more PsyD programs in trainees than PhD trainees, but I can't tell where they're from. I mean, I don't pay any attention to it once we've got them, and I don't remember, and I don't try to remember. Some people make it obvious, but some don't. So I don't think it matters, because in my opinion, the old accreditation criteria were so broad as to be meaningless. I mean, you didn't know what to expect, and you don't know what to expect at the other end either. What a person's going to know. And actually, it's a good time to for new training directors to take over programs, because they've changed the whole system, the accreditation system. So people like me, who have 7 times been responsible for all the paperwork, including 4 or 5 programs at a time, hundreds of pages, the self-studies, for the self-studies, it's a whole new system that's going to have to be learned. And I just assume let my successor learn it. Because I really don't want to hang around and do 8 more of these with a different system. With a different system.
It's a different system, yeah.
It's a different system. And that might be better. The other thing that's changed a lot is competencies, okay? The concept of competencies.
Yeah.
And there are so many competencies now that it's hard to keep track of them. And APA, the last time they came out with their set, kind of hierarchized them, which makes it more difficult to understand than just a list, So I counted 52 competencies and sub-competencies in the most recent one, okay?
Wow.
Now, the interesting thing was, one interesting thing is we tried to find out if these competencies existed with our interns, in our rating forms, and in our exam. So, for example, if we had like an assessment dimension on our oral exam, we expect that if there's a competency in assessment, that's going to have some relationship to how the supervisor rates the person on assessment on the rotation, that there'd be some correlation. But we found out that 0. There is no relationship whatsoever. And it's probably because what somebody is learning in assessment, there's no uniformity is one reason. Because what do you learn what are you going to learn in the inpatient psychiatry versus the pain clinic?
Right.
You're going to learn different assessment methods, but it's going to be called assessment. And the fact is, there's so many diverse methods. You just do say, okay, MMPI, Rorschach, Waze, everyone's going to know that, okay? Except that doesn't happen anymore. We had one fellow who's seriously mentally ill. She came in, she had never given an MMPI in her graduate program, and she had never had one on internship. And this is from 2 accredited programs. So this lady shows up, and she confesses to us. There was nothing, she didn't claim anything on her CV. She confessed that she has to learn all this stuff. So, we started to have her do a whole bunch of stuff that she's already got a PhD, But I'm telling you, it's unbelievable. So you don't know what people know. And this competencies things is a little shaky, in my opinion, as a concept. I mean, people sit around and they agree that these are the competencies, except nobody has tested them whether they exist in reality. So we found out they didn't exist. The one that might exist is judgment. Is clinical judgment might exist. That was actually not bad. But things, assessment, intervention, we couldn't get any kind of correlation at all. And we had 40 trainees, 40 interns. This wasn't like 2 interns or 3 interns. We had 4 years of data on this. And the only thing that correlated reasonably pretty good was clinical judgment. And when we sent in this paper, we tried to call it identification of the clinical G. And they told us that was they told us that was grandiose, and they made us change the title and water down the discussion a little bit. But I thought we'd go for broke the first time and let them tell us it was excessive rather than do their thinking for them, But I still think that there's something there, and I'm still going to try to continue as I'm like you have to designate a primary investigator at the VA for every project.
Yep.
So I think I'm going to try to see if I can get consultant status. If I can get consultant status, if I can get consultant status and keep working on this project, because there's 2 or 3 of us are working. Kim Schaub's got a piece of it, and if you know Elizabeth Painter, if you've met her. Oh yeah, she was over there, right? Yeah. She did a postdoc. Yeah, Painter and Rasher and this, and Kevin Young, our boy genius. He's our numbers guy, and so we're going to try this. This G concept. because I think Kevin is smart enough to be able to try some trick statistic that would demonstrate it. But there's no evidence on this stuff, and they're going to go and they're going to make this a national system. You know what? You know, it's not going to be my problem. I can be a discussant on panels. Not like anyway, so I'm good with competencies, but they need to have some kind of objective base or empirical base so that there's something to them. I mean, just common sense like assessment, that's not good enough. Because what people are learning is something more discrete, like a skill or a proficiency. It's not really a competency. I don't know what you would call it, but it's not broad enough to be a competency. It's a technique or a skill, you know, and anyway, so I hope that's one of my projects for my post-VA. I don't consider it retirement. I consider it's a term they use in the federal service, but it's post-VA career. Yeah, post-VA, because I have a strategy for that.
Well, Bob, we've asked you a lot of questions, and anything else you'd like to touch on?
Yeah, well, there was a topic that was mentioned about the public service, and because I did 10 years on the Geauga County Board of Mental Health and Recovery Services, and I want to tell you, that was an eye-opener. So I've been practicing almost 40 years before I got involved with this, and I never practiced. I lived in Geauga County for almost 40 years. No, 30 years by then. I lived in Geauga County 30 years. I had never practiced in the county. And in fact, I didn't know what services there were in the county. I mean, I knew there was a practice up in this medical building and another guy over here in the bank building, but I didn't really know what was going on. So my terms having expired on a couple of other boards, that's if I needed to look for something to do. I said, this would be kind of interesting. They were advertising for board members anyway. So I put in for it, I interviewed, and I got it, and then I wound up chairing this board. And I really say it was remarkable. You know, like, let's say I have a belief, primary prevention, okay? We need to talk to fifth graders about drinking and marijuana and bring in a drug-sniffing dog and, you know, have everybody pet them and all this stuff. Okay, fine. Now, but when you're trying to decide what to do with your money, whether you're going to give a few of these lectures or you're going to try to provide services to some bipolar guy who's running around on Route 306 and might get himself killed by an automobile, you have to think hard about where you're going to put your dollar. And it's really fine to believe that primary prevention is best in the long run, but you've got an immediate need here, you know, and you get cut back by the state, or this happens, or you need a levy. And it really makes you stop and think, and it's really been an eye-opener for me. The other thing is well, how can I say it? My psychology skills have helped, you know, like running groups, have helped manage these meetings, which there's a combination of psychologists and citizens and professionals, and there's always 2 or 3 mental, you know, SMI people, like bipolar or schizophrenic, and so there's 2 things I learned. If you want, and I'm in favor of spending money. I mean, I've never voted against any kind of levy. I voted for levies in my township that lost 9-1. I mean, because I said you got to invest money in the community, even if some gets wasted, you know. Anyway, so we were talking about getting these apartments built for homeless SMI, and this was when the housing was low. Like, all these people building wanted business, and there were arguments on the board about should we go into debt and should we get a bank loan, and we don't have enough money here, and are we going to get a grant? And our executive director, Jim Adams, is just a great guy, and he's always prepared for everything. So we were discussing this for months, the monthly meeting, and I said, I'm really tired of doing this. We need to get this thing, get a motion. So I come to I go to my next board meeting, and the 2 people who are most vocally opposing this aren't there. So that's it. I'm going to force the vote. They aren't here. They're not going to talk, and it's 2 votes less. So I really forced the vote. I manipulated it and forced. I mean, process-wise, got someone to make a motion. And when these guys saw the minutes, they said, "Well, we mean we might have to go $1.2 million into our reserves, but that's what passed." And I said, "Well, how'd this happen? You weren't here." You know, so kind of doing that. And then the other thing is managing the process and assuring sufficient respect for the mentally ill people. Okay, because, you know, they'll get up and they'll say something, be tangential, not really super crazy, but it'll be tangential, or something will be off the point and they'll go on, you know. And every so often someone on the board, usually not one of the mental health people, but someone, an attorney or a citizen or whatever, you know, come in and say, you know, you would have that person stop and not talk because they're wasting our time. And I say to them, listen, I say, that person has every right to be as irrelevant as you. and that's usually done. You or me, I'll say, which is true. I mean, people are always talking about stuff. Look at me here, you got me started. So that was my public. That piece about the public and respecting, the clients, even when they're just acting as citizens. I mean, I think that's very important to show people.
And so you'll have more time to follow baseball.
I still follow baseball quite a bit.
Yes, it's one of your passions.
Yes, it is. Yes, it is. And that's time to follow baseball. Yes. What else do I follow? Pretty much.
Pretty much baseball, not University of Michigan football.
Yeah, University of Michigan football too. Browns,
Browns.
And, it's our mutual friend and colleague Rick Sherrill. One time I was, this was when my son was 5, yeah. He was rooting for the Oakland A's, okay? And I was bemoaning, who were winning championships. This was 89, 90, okay? And I'm talking to Sherrill at lunch, and he's telling me that, and I'm saying, he won't root for the Cleveland Indians, and he's not modeling, not identifying, and I'm so disappointed and stuff. So Sherrill says to me, he's rational. He wants to root for a winner. You're the one who's irrational. You're rooting for the Indians. Sherrill will tell you that was an actual dialogue we had. So that was it. So I'm trying to do that, and one of the other things I've got some of these history projects. I'm going University of Akron archives, Cummings archives now, and David Baker have been very nice. I take the interns down there. Every year, and the postdocs I take down if they want to go. That's another example. So we got interns and postdocs. I insist on treating the postdocs like PhDs and the interns like trainees. And I'm I'm prescriptive with the interns. So you guys, we're going down in a group. We're going to the archives. The postdocs, I say, do you guys want to go to the archives? If there's 4 of you, we'll go down there. But they're PhDs. They can decide what they want to learn about something like that. It's supplementary and not part of the professional training. So we try to make these distinctions. That's part of the identity development. But so I'm going to try to spend a little time down there. Because I'm very interested in 1946, 1947, when all of this got organized, all professional psychologists decided APA and the practice organizations were going to become one group and have divisions. And they decided there was going to be accreditation. And they decided there was going to be an ethics committee. And they decided there was going to be board certification. And they were going to move board certification out of APA because APA was a membership organization. And you couldn't have a vote of just members control a competency evaluation. And I'm very interested in all these people. It's like an interlocking directorate. Like David Shakow, the schizophrenia researcher. Mm-hmm. He's on more than one board, and David Wexler's on more than one board. So these guys are controlling this whole process in maybe 18 months, and you can read it in The American Psychologist. And I dug into the papers of some of these guys, and there's just amazing stuff in there. It's just very interesting. So I'll have some time to do that. And I've done some editorials, historian columns for the APEP specialist, but I'm going to turn a couple of those into articles, I think, once I get a little time. So I got a little of these kind of no deadline intellectual projects that I'll have a little time to do. And I plan to continue the amount of independent practice I'm doing now, which is chiefly forensic and some psychodynamic special type cases that fit that modality, and the psych testing that I'm still going to work at. So,
what advice would you give based on your knowledge of history of psychology, your 40 years of experience? What kind of advice would you give to new people in the field, early career psychologists, people thinking about getting involved in psychology?
You need a hobby. You need a professional hobby. Okay, whether it's OPA, ABEP, community service. It's very useful, like when your job is not going right, if you're invested in it because it's your career, that you have some kind of professional hobby. And I found that was, to me, an important thing when I discovered professional hobbies. And it ought to satisfy 2 criteria. Number 1, you ought to have the skill set, okay? And number 2, it needs to be fun. It needs to be something enjoyable. It's going to be a pain in the ass. Don't do it. So, for example, I got into this newsletter thing so I got asked to do a newsletter. Well, I like photography. I mean, it's fun for me. Okay. I can edit stuff. I can word process and type. I'm not reliant on volunteer typists or somebody in central office or bothering my VA secretary, which wouldn't be appropriate to do this stuff, you know. So plus I like schmoozing. You know, you wind up meeting all these interesting people, and you have some connections, and it's professional schmoozing, and so I like it quite a bit. So at one point, I got asked. I was getting interviewed to edit the ABEP specialist. That was called a diplomat, and the president of ABEP was on there, and she says to me, "Would you do it twice a year?" I said, "Yeah, I'll do it twice a year." And they said, "We're considering doing this newsletter 4 times a year." And I said, "Oh, jeez." I said to myself. So I said, "I won't do it 4 times a year." She says, and I told her what I do and what I wouldn't do. I'll do it 2 times a year. I won't do it. Then she asked me, if we do it 4 times a year, would you do regional letter or something? Yeah, I'll do that. I said, but 4 times a year, I don't think I can't do it. I'm doing other stuff. In practice, I was VA. So it always worked out. Everything I've done has been fun. In fact, they've had to depose me from 1 or 2 of these things because I'm so fond of them. But I've learned to realize my time is up. The other thing is when you're doing something, especially if you get in a more advanced part of your career, stage of your career, you have to realize that you get to a point where it's time for you to go, and it's better for you to realize that because it's very hard for your colleagues to have to tell you that. You put them in a very bad position. They're embarrassed. They like you, but you're not doing this, or you came to the meetings on the wrong days and you can't keep things straight, or you really would rather be out fishing than doing a newsletter. So you have to recognize this in yourself, and that's much better for you and better for everybody. You had a good time with it. You leave on good terms. You've prevented embarrassment among your friends. You've averted awkward situations. So that's been my philosophy as I get into more advanced stages of my career, and start to get out of stuff while the getting's good. Before somebody tells me to take a walk.
But it does sound like it's kind of hard to let go.
Oh yeah, but you have to accept that. That's good to have something else to kind of save you on to. Yeah, it's hard to let go, but
Well, Bob, I think I've known you many years, and we've done a lot of reviews of students' work together. And I think one of the things that I always appreciated was your enthusiasm. It could be a long day, and you still were enthusiastic. And you always treated the students fairly.
Well,
sometimes there were terrible presentations, and yet you handled that very well. And there were times that supervisors did a terrible job, a poor job of preparing. What you did about that, I don't know.
No, I sat down at the end of the year with every supervisor. At one point, before it got, about 4 years ago, I stopped doing it. I had no time because I was writing these self-studies for APA. But I did sit down with every supervisor and went over the pros and cons of the supervisions and the case presentations.
Well, you were ever enthusiastic and positive during those presentations. And I think the students gained a lot from it. And I know they appreciated it because often they thought that they were going to be roundly criticized, kind of following the medical model, you know?
Yeah.
And I will tell you that this was a result of your having consulted all these years. I think we started doing this while you were still able to consult for us. But we would meet after the case presentation. The consultant, and the intern would meet, and we'd have a little more frank discussion. You were doing that too. That's how far back I was doing that. And I thought that was very good, and the students loved it because they get some straight from the shoulder talk, but they're not embarrassed in front of their peers.
Right.
And really, it's got. And I think that occurred to us when you were discussing some of the downside of not being able to say in front of the other interns what you'd want to really tell the student. And really, I think you contributed to that, I think.
It was important to make sure that it was a positive learning experience for the student. And when they didn't do well, remind them, look, you're still a beginner, and you'll make mistakes. We did.
Right.
but you were always enthusiastic and positive, and
Yeah.
So I'm remembering a Bob Goldberg story
Uh-oh.
now. So one of the things, as Dick was talking, I really admire about you, Bob, is how reliable you are. And as a trainee, you can't really underestimate that. You know, supervisors change throughout the year. The training director
Yeah.
stays stable. And, you know, you had a lot of stability in general in the program because you'd been there so long and really knew the institution so well. So a good example of that stability and reliability that you lent to the program, we were having a group supervision episode, and we're sitting down together, and they're predicting a big snowstorm the next day. Big snowstorm predicted, and I live out in Geauga County, Chardon, and I say to, you know, Dr. Goldberg at that time, you know, I said, I don't know, you know, they're predicting like 2 feet of snow, you know, if it's bad, I might not make it in. And, you know, Dr. Goldberg looked at me and he said, I have been working here for 30 years and I have never missed a day because
That's
of
true.
snow. You can get on Route 20 and you can crawl on it 20 miles an hour to get there because that's what I'll do if I need to get there. And I said, all right, well, I got it.
There you go.
And that work ethic and that reliability, you know, I think all your trainees knew that you would be there for them no matter what.
Thank you. Yeah.
So I think we're drawing to an end, but I just want to thank you again on behalf of OPA and Ohio Psychology for sharing your wisdom today, and it was a pleasure.
I'm flattered for the opportunity. I had a great time, and you're so very welcome.
thank you.